Welcome back to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Program, and we're proud to be a community partner with Forward Radio WFMP LP 106.5. The views and opinions expressed on Single Payer Radio are those of the speakers and not the station. We're recording today's show Wednesday, May the 12th, 2021. Eula Hall passed last Saturday at 93. She was a relentless advocate for healthcare in Appalachian, Kentucky. Against so many odds, she started the Mud Creek Clinic. Dr. Garrett Adams gave me a copy of that book a few years back. What a story. Thank you, Eula Hall, for all your work. And May is Mental Health Month. I don't think 1 month will do it justice. Seems like mental illness is challenging COVID as our national epidemic. Are you listening, Senator Dr. Rand Paul? A couple suggestions. One, listen to Two Nuts in a Pod here on Forward Radio WFMP 106.5. It's a great show discussing mental and emotional wellness. And the second suggestion is donate or volunteer with Forward Radio. Just go to forwardradio.org. You'll feel better for it. And nobody's wearing a tinfoil hat in this studio. Dr. Mike Flynn?
No, Joe, I don't have one, so we'll move on. First of all, let me begin with the usual disclaimer that any views that I express today represent my personal views and do not represent the views of the University of Louisville or the Department of Surgery.
My views are my personal views and don't represent Taylor Regional Hospital in Campbellsville, Kentucky, nor the Department of Surgery at the University of Louisville.
So we have a special guest today, George Nichols. George is a forensic pathologist, and I'm going to ask him to define that for our listeners, who mostly are not medical folks, when he has a chance to make his opening remarks. George went to medical school and did pathology residency at the University of Louisville, took a fellowship in forensic pathology. He was a state medical examiner for a number of years, where he earned the title of Dr. Death, and currently runs a consulting service. So George, welcome, and we really appreciate your willingness to do this. What we've done in the past is allowed our guest speakers initially an opportunity to make whatever comments they'd like to make about the topic, which in this case are going to be an assortment of medical legal issues, and then we'll let the conversation begin. So the floor is yours, and maybe you could just begin defining a forensic pathologist for our listeners.
Well, pathology is the study of human disease and the body's reaction to that disease process. The pathologist is the doctor who examines the tissue biopsy that's taken from you or examines your pap smear. So that's what pathology is. It's the primary course in the second year of the 4 years of medical school, the purpose of which is to try and teach students about the biologic history and evolution of the human diseases. So when they see a patient, they don't know where in the evolution of that disease it is, but they must make an assessment of the condition of the patient and try to make the proper diagnosis and institute effective therapy. So that's the purpose of pathology. The word forensic means law applied. Therefore, theoretically, anything having to do with the law and human disease is the purview of a forensic pathologist. In actuality, and in day-to-day practice, the vast amount of a forensic pathologist time is spent in an attempt to determine, if we can, how a person goes from alive to dead. to do that, we use a large surgical procedure. It's called an autopsy, and those are performed in autopsy suites. And the main thing that's featured in an autopsy room is one or more stainless steel tables, or SSTs. And I've spent a great deal of time standing around SSTs, so much so that the veins in my legs are no longer competent, and I have to wear compression socks to not slosh when I walk. How about you, surgeons?
You're breaking my heart, George. I used to wear them when I did those long 13-hour procedures. I stopped when I started doing endocrine surgery in the last 10 years of my practice, because most of those cases lasted anywhere from 20 minutes to 2 hours.
Right. Well, an autopsy lasts anywhere from 2 hours to 2 hours.
You know,
Sometimes.
I remember those good old days when I was in pathology. Gene, do you want to begin the discussion?
Well, one of the things we're going to talk about is medical malpractice. And most physicians feel like that the medical malpractice in the United States is a huge issue. It's also an emotional issue. And of course, one of the reasons of this radio program is unipayer system, and that we need to switch to some other type of system. And I want to ask George, if we switch to a system where everybody is covered and their medical bills are covered, what will that do to the medical malpractice situation in the United States? We won't have to sue someone in order to get money to pay care of their disability as a result of medical malpractice.
Well, I'm not too sure that it's going to change anything, because to change the litigation, it's going to require activities of, I hate to say it, the state legislators. And we know how effective those guys are in thinking long-term and short-term. I dealt with the budgetary issues for my little portion of the state of Kentucky for 21 years, loved every second of testifying. And there was a guy who was in charge of one of the budget committees, I've forgotten whether it was House or Senate, absolutely hated me because he was a criminal defense attorney, and I had been in trials where he was representing people who were found guilty. Now try and get some money out of that guy. So I don't think the doctors can do anything. It has to, because all medical negligence, like 99% of medical negligence actions, occur in state courts. So it's going to require state activity. I'm a second generation doctor. My father was a family practitioner near Shively, Kentucky. I'm divorced from a doctor. I'm married to a doctor. And interestingly enough, the three sons that my second wife and I have, none of them ever wanted to be a doctor after seeing what it was like to be a doctor. So I'm in it for the duration. I'm still working at least 4 hours a day, and I'm still doing some autopsies, although the arthritis in my hands has made it very unpleasant to try and perform the operation without inflicting painful injury on myself. So I don't think that the unipayer system is going to do much of anything in terms of medical negligence. That it's all going to be on the states. Now, Indiana reformed its its malpractice litigation 30 years ago, when, amazingly enough, the governor was a doctor. And so they set up a system by which a complaint would be made, it would be referred to a board, and then the board would make a decision, yes or no, with medical negligence had been committed. Then that was challenged in court, and that's been changed. And now there's a way for the board's decision to be sent directly to a circuit court for at least a hearing, if not a complete trial. So all the Indiana law has done, as near as I can tell, is to slow down the already slow procedure for all parties concerned. So that's the way. I don't know that a single payer system is going to deal much with medical negligence.
George,
Sorry.
I've had 5 children and nobody has any interest in going into medicine either. So I guess it's, what they see, they didn't want to do. Let's go back a little bit into the medical liability issue. Where is it today? Is it up, down, or steady?
I can't tell since COVID occurred, because the number of for a long time, the number of elective procedures were not being performed at all. If it's a traumatic event, there's not going to be much in the way of liability issues. Almost all of the liability issues occur with the management of elective disorders by diagnostic procedures or by therapeutic procedures. So those haven't been done. So I don't think right now anybody can tell you how many cases are sitting out there that will occur in a delayed fashion because of the pandemic.
Yeah. Now, I, as a surgeon, I've had about, I'm going to go through all the gory details, probably been sued about 5 times. A couple of them were disposed of by judges. One went to trial and one was settled. The one that went to trial back in 2010, the plaintiffs had a quote, expert witness. This was a professional expert witness. He was an otolaryngologist from New York who the file was about 6 inches thick. His main occupation was testifying in whatever kind of medical liability issue they asked him to testify in. In my case, it had to do with the treatment of hyperparathyroidism. I went through the file. He testified about everything from hearing difficulties to tonsillectomies that went on and on and on and on. And the way the law was written, the way I understood it, all you had to be identified as an expert witness is be a physician. And we all know that the difference between somebody talking about the treatment of breast cancer, gynecological problems, or whatever else has a lot more than just being a physician. Where is the medical liability issue in terms of what I would define as an appropriate or a real expert witness, as opposed to some guy who just decides to testify against any, whatever they want him to say?
Well, I was surprised that the judge allowed him to testify. Kentucky is a Daubert state. We accepted the Daubert standard in 1996 or 97. In fact, I taught the first course about the Daubert to the judicial conference. That's all the circuit and appellate court judges in the state of Kentucky. I think I taught that in 97. And the Daubert standard is that you must be board certified in the field in which you are to give testimony, as in your guy should not have been qualified to testify about something going on in a toe, since he was an ENT doctor. So then if you have an opinion and you're going to express it in court, you must be able to cite a peer-reviewed paper or more that will back up your opinion. If you do not have a peer-reviewed paper, you will have flunked the Daubert test and your testimony will be withheld. I don't know if the Daubert motion was made in your trial or not, but the judge should have not allowed him to testify unless he had peer-reviewed materials to say he was correct.
Wow, this goes back to 2010. I don't remember. He was an otolaryngologist. He did 1 or 2 parathyroidectomies a year, as opposed to 50 or 60 that somebody who does a lot of parathyroid surgery would normally do. But but he was a board qualified otolaryngologist, to be fair. I doubt very much that he had a peer-reviewed paper about the issue that he was testifying with in court. And well, who knows?
If we talk to trial lawyers, they're going to say, well, the cost of legal proceedings in medicine compared to the entire cost of medicine is extremely small, less than 1%. The real issue, as I see, as far as the cost of medicine, is defensive medicine. And we have doctors who, including me, who order too many tests in order to defend themselves. And I see that as one of the biggest problems of the increased cost of American medicine compared to medicine in the other industrialized countries around the world. And how do you feel about that, George?
Oh, I agree. I review lots and lots of medical records, and especially in teaching hospitals and teaching programs. The practice of medicine is done by protocols. Nobody thinks necessarily about what's going on with the patient, but there's a protocol. I have these few findings, and here's what here are the lab tests that I'm supposed to start out with. And you can pursue almost any laboratory test to the nth degree. You know, laboratory tests are meant to be 95% accurate. So if you do 20 tests, you have a very good chance of having one that is a lab error. No one considers that, and they chase it. So they spend a lot of money chasing something that's felonious in the beginning. So too many. I can't tell, since I'm a lab guy, I can talk about the lab side. The anatomic stuff, the biopsies are probably appropriate in their uses, whether it's on skin or gynecology or breast. But from a clinical laboratory standpoint, there's clear overutilization, and I don't know how you control it.
George, one of our earlier programs, we had Mary Berry on. I don't know if you remember Mary. She was a internist for many years in Louisville, retired. She was my wife's physician. She was a great internist.
She was my physician until she retired.
Okay.
I used to drink beer with her dad, who was a sports writer for the Louisville Times, and I knew Mary when she was a nurse at the Denville Hospital.
Okay, well, I get back to the question. We had her on to talk about telemedicine. And as we talked, and there were a whole number of what I would consider legitimate medical, legal issues. So let me run some of those by you. First of all, the sort of medical license waiver issues where these organizations that do telemedicine may have especially with the pandemic, allowed somebody with a license in West Virginia to be giving advice in Kentucky. I mean, I guess those things are going to go away when things tighten up after the pandemic. The other issue was confidentiality. I mean, we're talking to you on Zoom, and Mary was doing the same thing with whoever she was giving medical advice to, or, on a computer. What are the issues related to either or both of those aspects of telemedicine?
Well, first of all, the act of the laying on of hands is abandoned when you're pixelated, and it's pretty much abandoned with medical education these days.
Yeah,
the value of the physical examination is not just for reimbursement issues. It's you can learn things from touching people, hopefully with their permission. But you can learn things, and sometimes physical examination you'll never get the story, as old Dr. Roseman, the neurologist, used to say. The story, go get the damn story. You start off getting the story by having an intimate interview and by instituting the process of doctor touching patient. That's gone. How do you do this? Pixelated. I mean, I gave testimony yesterday in a trial in Monmouth County, New Jersey, via Zoom, and I'm going, this is the weirdest thing I've ever done. You know, I'm used to seeing jurors sitting right in front of me, and there were none visible. All I saw was my iPad. That's it. So I think, and especially if the charges are less for Zoom medicine, the insurers will drive it that way, not for the betterment of the patient or the betterment of the doctor, but for the betterment of the corporation and its shareholders. Oh, excuse me, and a CEO or two.
Yeah. Well, the other question, which I remember asking Mary, and I don't think she had an answer, was what, people make mistakes. So what happens when you give bad information in a telemedicine setting where you have only had an opportunity to talk with the patient or even just look at them through a computer? And you may not get all the story. It's just an interesting situation. Or if you have somebody who happens to be doing the telemedicine thing, who is basically incompetent or over their head in a particular situation, you've got a gynecologist giving advice about neurosurgery. Where are all the medical liability implications of that? I mean, I don't know how that's going to work out. Have you had some thoughts about that? This may not be a fair question because it's such a new issue.
Well, I've had some thoughts about it because the analogy you started with was a West Virginia doc taking care of a Kentucky person.
Yeah.
By Zoom. Now, and I told you that this is primarily state regulated litigation.
Right.
Which state gets it? Is it the receiving patient's state who files the practice? Do they file it in Kentucky? Do they have to file it in West Virginia?
Well, that's what I'm asking you. Yeah.
because the West Virginia doctor's medical negligence insurance is going to cover his activities, unless he has a special clause written in it, for his activities in West Virginia alone.
Yeah.
Now he's still in West Virginia when he's doing medicine by Zoom and Pixel to somebody in Kentucky or California. But where does the act get filed? So, and there, each of these states have different laws, portions of their medical negligence laws that are different from one from the other. So, I'm baffled, and I'm really glad I'm not a lawyer. Of course, I'm glad about that every day.
You wonder where all this is going to go, Jane?
Well, I want to bring up one of the other big issues is electronic medical records. When I bring this up, and for some young people around, they'll say, well, you're just an old guy who doesn't know what he's doing and just doesn't know how to use the electronic medical records. And that partially is true. But I've noticed that they don't fit together. For example, let's say we have an 85-year-old patient who has atrial fib, and they go in and out of atrial fib, and the cardiologist doesn't want to use an anticoagulant because of the risk of him having a stroke or other problems. So if you push all the buttons at the end of the story, you got a patient that's got atrial fib who's not on Xarelto, and it's hard to figure out. Well, in the old days, when we had a regular H&P, you'd dictate, well, this gentleman is an intermittent atrial fib. He's not on anticoagulants because of the risk, and it would be very clear. There are multiple issues like that, and I think that's what you're feeling about how electronic medical records are going to affect practicing medicine and the legal issues.
Well, there's a huge amount of redundancy in the electronic medical records, where entire histories and physicals will be repeated over and over again in a patient who may actually have a different story, but the other stuff, the baggage, is still included, even for diseases that they no longer have because they've been eliminated. So the idea of electronic medical records was a good idea. So, I mean, I don't know about you doctors, but my handwriting has deteriorated like crazy. So my writing was awful. My typing is not much better, but it's correctable. And so just to be able to effectively communicate on paper was difficult for doctors to do anyway. So this theoretically is better. It's easier to find results from laboratory testing, radiographic testing, and other evaluations. So it all is fairly compact until you repeat the same stuff over and over again, and you get to thousands of thousands of pages if you actually print the stuff out. It's good for those who bill, both for physician services and services in hospital systems. Beyond that, I'm not too sure it's the world's best way of doing things.
Well, what's happened with, as you've already mentioned, in this country, the electronic health records are focused mostly on billing, not on medical care. This is not true in other countries. And if you look at the complexity of electronic health records in the US compared to some other countries, we had a Canadian surgeon on here from Hamilton, Ontario, and their electronic health records are just a whole lot simpler because they have a single payer system up there, and they don't have to navigate through this insanely complex system of billing for thousands of for-profit insurance companies, each with 20 or 30 different plans. Let's switch horses a little bit here. Let's talk about informed consent. There was an article I was reading, if I can remember all the details, in one of these throwaway magazines called General Surgery News. I don't know if you saw this, Gene. And there was a lawsuit in a state that this is a month or two ago, I can't remember where it was, in which the issue of informed consent, there was the lawsuit focused around informed consent and who should get it, and the issues that were revolving around, and the article, the purpose of the article was raising the question of in the trial was whether the surgeon was required as the person to get the informed consent for the operation, as opposed to having a resident do it, or a medical student, or a nurse, or someone else. And what that meant, because I know, at least in teaching hospitals and places like that, residents and fellows often get informed. I had a procedure done at U of L Hospital a couple of months ago, and the fellow got the informed consent, not the cardiologist who did it. So where you've got some, I don't know if you're familiar with that or what your thoughts are about, who's legitimately appropriate to get the informed consent, or is this something that has to be done by the operating surgeon or the surgeon in charge?
Well, I have some thoughts about it. Theoretically, it should be done by whoever's in charge. Notice how I said theoretically, but that's not necessarily possible, because it would require the physical presence of the operator at a time where the operator could not be there, because perhaps the operator is in another operating room operating on somebody else. And you can't just say, "Excuse me, I have to break scrub, go out and explain this and get a consent form signed." So that is physically impossible at times. Probably the fellow, if there is a fellow or a senior resident, would be the person I would think should be in charge of it. But again, especially if it's these are surgical people, they could be in an operating room in another hospital, doing what they're supposed to do, which is to take stuff out and put things back in. So it usually is going to fall to a nurse. The analogy that I do is for an autopsy to be authorized requires consent from the next of kin. If it's done in a hospital, then the nurse who is in charge of the removal of the dead body to the morgue is the one who is in charge of getting the consent. So she at least knows the family, knows about the dead person, and gets the consent. Now, how much she knows about what an autopsy is a whole nother question. But if it's a 4 o'clock in the morning death and I'm at home, I really don't want to drive in to try and get consent from a grieving family that I don't know. So that's how it works for a pathologist.
Well, the other issue that that this article brought up was the implication in clinical research that if a surgeon is the person responsible for getting the informed consent as opposed to a resident or a fellow, most of the clinical, I've been on the IRB at U of L for 15 years now. Most of the clinical research that's done, the consent is not obtained necessarily by the principal investigator. They have research associates and people like that who will sit down with the family. These informed consents are 25 or 30 pages long, and they go through all the stuff and answer all the questions. And if there are any questions that they can't answer, then the principal investigator would come in. The machinery of doing clinical research would really be gummed up if the principal investigator, who could be a busy medical oncologist, a surgeon, somebody in infectious disease, would have to spend all their time going through these detailed informed consents. So I'm not sure if this is a fair question to ask you, but whether you've got any thoughts about the issue of getting informed consent in a study that would involve, well, any of these COVID studies for the vaccines. I mean, I don't think the informed consents for the Pfizer, the millions of people or the hundreds, I think the first Pfizer third phase 3 trial had 30,000 patients in it. I doubt very much if the principal investigators were getting the informed consents to do that for that randomized trial. So, what are your thoughts? I don't want to be babbling on here for hours, but what are your thoughts about?
Well, I'm sure the primary investigator was not physically involved in going through the consents, but whether it's a lay person who works as a data gatherer for the primary researcher, whether it's once again a nurse who's there again to obtain the consent form, somebody's got to do it, and it would not be expected to be the primary researcher.
Well, one of the things that's bothered me is the lack of accountability by some plaintiff attorneys. Let me just give you an example. I got sued once. I had a patient that had a lipoma on his back, and we took him to the operating room, and physical examination pre-op was normal, and we hooked him up to the monitor, and he had atrial fib. We took out the lipoma under local, and then I went back and told his wife and the patient that he had atrial fib, and called his family doctor, and we referred him to a cardiologist. Well, he sued me for causing him to have atrial fib. And this went on for 2 or 3 years. I mean, you don't have to be really smart to figure out that I didn't cause atrial fib, but it looks like the attorney should have some accountability and just saying, well, we're sorry we filed this suit and we're dropping it.
Gene, did anybody ask him whether he drank a liter or a fifth of bourbon every day that induced his atrial fibrillation? I know you're in a dry county, but things happen.
No, it's wet now.
Oh, it is.
Yeah, you need to come down. Well, I've got a cabin on the lake and a boat. We'll have a good time.
Yeah, I've stayed in the cabin. There are more dead animals hanging on the walls or hanging off the ceiling than I've seen in any place in my life. Let me tell you, Jay, I got a better story than you have.
Okay. I know what this is.
No. This was probably 15 years ago. I saw a woman in the office who had a goiter. And I examined her, looked at the ultrasound and talked with her about it. She was totally asymptomatic. And I advised her that, in my opinion, she really wasn't a candidate for surgery because her thyroid was maybe, I don't know, 70% bigger than a normal thyroid. And she was a moderately heavy lady, and she didn't have a big football-sized goiter in her neck. So she went back to a town in Indiana where she was operated on by someone else. And during the course of the procedure, they damaged her recurrent laryngeal nerve that goes to her vocal cords. And they sued me. And so we went up with the defense attorney, and I went up there and we took a deposition. And the premise was that since I was a head and neck surgeon, that I should have operated on her because I had more experience doing the surgery than the person that operated on her. And if I'd operated on her, her nerve wouldn't have been damaged. I mean, the judge threw that out, but I mean, if you try to think the distorted logic of that is just this mind. It's almost the same as your atrial fibrillation thing.
That's just like some of the stuff that's going on in Congress today. It makes no sense at all. I want to change the subject just a minute. I want to go talk a little bit about the coroner system. Kentucky's got a coroner system that's each coroner is a constitutional office. Do you think that's a good system for the state, or?
Of course it's not.
Okay.
I came back here as the first chief medical examiner, so I was the first forensic pathologist in the state. I looked around and I said, well, there aren't any others. Why not? And I found out that there was no support system for them anyway. This is a big state. It doesn't seem like one, but east-west, it's a long way from Pikeville to Paducah. So you're going to have somebody authorized as an investigator other than the cops. They can work with the cops, but you have to have an independent evaluation simply because sometimes things happen during arrest and at the hands of police officers. So it has to be somebody other than the cops. When I wrote the coroner and medical examiner statute, I think 78, there are several things that I did not include in there. I listed 14 things under which an autopsy would be authorized, but I did not have means to replace to place enough forensic pathologists in facilities that didn't exist either. You have to understand, 2% of physicians are pathologists. 2% of pathologists are forensic pathologists. So we are rare. It's also, I think, the only specialty I know where you take more training to make less money because you're primarily a governmental worker. That's why I always had a moonlighting job, one or more, in doing laboratory medicine. Governor Brown's
George, you're breaking my heart, man.
Well, Governor Brown said to me, he said, "Well, what does this lab do?" And I said, "It does stuff on live people, Governor. For you, I do things on dead people." He said, "Okay, I understand." So that was okay, but the maximum number of forensic pathologists we've had working at the same time in the state of Kentucky, by my count, was 9. There were functioning offices in northern Kentucky, in Madisonville, Kentucky, in Madisonville, because that's where the roads all crossed, in Lexington at the university, and in Louisville, also at the university. I was never able to get the 5th office that was necessary, should be necessary, in southeastern Kentucky, home of much violence and many drug overdoses. And London is where the roads also would meet. But there's no way that the medical examiner can be in 2 spots at the same time. And as I said, it's a long way from Pikeville to Paducah. You would have to have a hybrid system in which medical examiner investigators placed locally would replace the scene investigations done by the coroner. Good luck getting the money for that. The coroner's offices are supported by a county government, as opposed to the medical examiner's office that would have to be supported by state government, and trying to squeeze Nichols out of the Commonwealth of Kentucky's treasury is extremely difficult and frustrating. So no, the coroner's office I've railed about for a long time. There was a headline in the Louisville paper about 1978, when I was trying to get that law passed. It said, "If you want to kill your wife, do it in Kentucky. George Nichols." So it's improved because we now make everybody at least get trained and pass a certifying exam, although a 5th grader can pass the exam.
Is there a conflict of interest for an undertaker to be a coroner?
Well, theoretically, yes. Notice how I said theoretically. But if you have to have access to certain things, and I don't have to tell you, you're in a small town and surrounded by rural communities. You have to have a place to put a dead body. If you have a hospital, does the hospital actually have a morgue that's functional that you can put the body in to examine it, just to take photographs, do fingerprints and stuff like that? There's always going to be a funeral home with an embalming room where the similar type of examinations can occur. And before we had EMS services, the undertakers actually ran the ambulance services in rural Kentucky. So they're helpful, but it is at least a potential conflict of interest. I have worked with many coroners and deputy coroners who are funeral directors, many of whom do a great job, some of whom do a moderate job, and some of whom do a lousy job. I couldn't remove them.
I remember the days when the funeral homes ran the ambulance services, and there was a big wreck. If there were 2 funeral homes in town, they would each race out to the wreck, and the one that got there first would take the dead body, and the other one would take the one that's alive.
All right, George, let's change horses again here.
Make sure you don't put any fungal medicine on your horse.
Okay. Let's talk about the opioid crisis, Purdue Pharma and the Sackler family. So, this organization literally changed a lot of the way medicine was handled. I guess it started back in the early 2000s, or maybe even in the late 90s.
It was late 90s.
Yeah.
I know, because I was still the medical examiner, and that's when I began to see the O drug.
Right, and the folks were these very skilled and attractive people were sent out as representatives of the pharmaceutical company. They went to physicians' offices as they basically changed the vital signs. So your 5th vital sign became pain.
They didn't. That came from a letter to the editor in the New England Journal. That's the source.
Yeah, but it was driven by this focus on providing some pain medication that was supposedly not addictive.
Yeah, it's going to be,
Which was not true.
We're not supposed to have patients in pain. But they all drew upon not an article, but a letter to the editor about the additional vital sign, that being pain status. And they're smart. Listen, this family has marketed all sorts of stuff. As I recall, I think they were first in the benzodiazepines, and I think Valium was one that they pushed with some regularity. And I'll use the word push because that's what they were doing.
Remember, Joint Commission also pushed this very heavily. We had to put signs in the ER that pain is a vital sign and you shall not be without pain.
I know, but it was I know where they came from, but the basic background force of this was driven by the opportunity to market and sell and get used this medication that turned out to be extremely addictive. So George, from a medical legal standpoint, who's responsible? I mean, different organizations have sued the company, they've sued the family. I'm not exactly sure where all this, where the dust is settling.
Well, we've also had many pharmacies who have been found guilty of criminal activity by illegally dispensing the same controlled substance here that you're talking about. And I, in fact, testified in multiple trials involving prescription drug overdoses containing always at least one opiate, if not more, by physicians who were writing prescriptions left and right.
Yeah,
many of whom were not trained as pain physicians. I mean, one guy was a cardiologist. Why is he writing oxycodone?
There was a town in West Virginia where over a period of 5 or 6 years, the town of 400 that had dispensed over billions of these opioid tablets.
Correct.
I can't remember the name of it. I gave a talk at Grand Rounds the year before I retired. But where does the response? If you pick off a pharmacist here or pick off a physician there, I mean, these people deserve what they get. But the fundamental issue was that this very powerful, very skilled family that was running a pharmaceutical company was using as much influence as they possibly could to get this thing into people.
Correct.
Where is that now? I think they file for bankruptcy and they took a couple of $1 billion and put it in a Swiss bank account or something like that.
Well, they filed for bankruptcy, and the bankruptcy judge was going to allow them to pay off the fines that they were going to pay by continuing to operate the company, which was continuing to make oxycodone. So, and that's a real good way of doing things. I don't think that the Sackler family has lost a house, a car, a blood relative, as a result of oxycodone distribution and sales.
So they are not held. That family that owns that company is not being held in any way responsible for the damage that was done over these 20 years of promoting the use of an opioid as a non-addictive substance.
Well, the family at this point is still in litigation. The company went bankrupt, and but is still allowed to operate and pay off the debts that the company accrued as the result of deaths associated with oxycodone. The family is still in litigation, and they are each individually billionaires. So, good luck to them.
Well, I think it's a combination of things that happen. I prescribed oxycodone, but it was always to patients who had metastatic cancer to their bone or having severe pain. Or I never gave it to people with benign disease. And I think most physicians should have been aware of that. I think most physicians should have known that it was an addicting drug. When Demerol came out, it was advertised that it was not addicting. So this is not a new phenomenon.
Well, yeah, but they didn't send out an army of drug salesmen to go to physicians' offices and take people on cruises and have them meet in expensive restaurants and give talks and do things like that.
But the other thing that bothers me is that we're still doing this. Some things that I think are incorrect. For example, the pain scale. I think that's grossly inadequate. I've made rounds. I used to make rounds with a nurse who she always asked the patient, "What's your pain scale this morning?" And somebody would be sitting there eating breakfast, bacon and eggs, and he would say, "Oh, it's an 8." I don't think I could eat breakfast without having that much pain. And then we still emphasize asking patients about pain. If you go ask somebody specifically about a problem, most of the time they're going to exaggerate it. There are a few who won't. So I think we're still trying to say that pain is a vital sign. Pain is really a objective thing that is different for different people.
Well, I don't think it's objective at all. It's a subjective
I mean,
feeling.
It's subjective.
It's impossible to scale pain. It's a falsehood to even think about using any type of objective scale for such a subjective finding.
All right, George, we're getting down to the last
But
5.
let me say one other thing. I do think that we're making progress. I'm seeing more and more patients who are being treated with nonsteroidals than with narcotics for pain. And people are gradually being taken off of narcotics.
Okay. George, I was going to say, we're getting down to the last 5 minutes. There's a couple of issues around medical liability activities I kind of like to get your views about. Number one, it used to be true is that a bad result is not necessarily malpractice. We all know, especially if you're a surgeon, things happen, and a bad result may occur not because of anything you did, but because of the clinical situation that you were in, or the physical status of the individual you're operating on. Is that a statement that from your standpoint, where you sit in your medical liability consulting office, and
I'm a causation. I'm a causation expert. I am not a standard of care expert, except in the rare case where it is an issue that involves pathologist, pathology, or laboratories. So I'm rarely, if ever, a standard of care person. So I can tell you that if I do an autopsy and I find what I find is what I find, and if that leads to litigation, then I will stand behind my findings, but only as causation, not for the standard of care for the surgeon in question. So that leaves me way away from
okay.
any involvement there.
And this next question may be just as may be just as inappropriate to you, but I'm going to ask it anyway, because one of the discussions everybody gets into when one of these medical when a lawsuit comes up is when do you settle, and when to settle and when to fight, or when to go to trial. Because going to trial has got some got some issues because you're dealing with 12 or 14 people. They usually 12 on a jury and two extras. Or is it just easier to settle? Do you have any thoughts on that? You've spent as much time in a courtroom, I guess, as anybody that I know.
Well, I've testified in thousands of trials. When I was the medical examiner, I averaged one trial per week for 20 years. Add those up.
Ooh.
So I've been there a lot. My reference, of course, is biased, because if you find out that Dr. Nichols, if you're the person who's being sued, Michael, and your lawyer has sent the case to Dr. Nichols to review, or I've performed an autopsy on it, and Dr. Nichols says, as a consultant to your attorney, settle, then settle.
Oh, I agree. I used to do, I did these reviews for both defense and for the plaintiffs. I did a number of these things for Larry Franklin.
The
And
late great.
on many occasions, there'd be a box on my front porch that had books, about 1,000 pages of stuff in there. And I'm assuming that I don't know what he did, because I never found out, but I would give him an honest opinion about whether this was something that was in an appropriate activity or action, or this was something that should have been settled. And I've done it in both ways, and I think that's really important. But there's a lot of emotional issues, a lot of emotional in there. So George, we're about done here. I want to thank you for your willingness to come on. You're as much fun on a Zoom as you were as a resident. I remember you were part of a group of people who did some kind of show back in medical school. I'm trying to remember all the details, but I knew you guys weren't going to make it to Broadway, but it was enjoyable. Anyway, thanks again. We're about done here. We'll sign off, and then we'll come back on and chat with you for a little bit.
Okay.
Okay. Thanks again, everybody. For more information about Kentuckians for single payer healthcare, you can go to kyhealthcare.org. It's kyhealthcare.org. For more information about WFMP-LP, you can go to forwardradio.org. Thanks again, everyone.